So again, welcome. I just want to update you on the Self-Direction Act of 2022. It passed both the House and the Senate unanimously. There were no nay votes. In fact, in the House, we actually got all of the members of the committee that it was heard in to be co-sponsors. So that was just a thrill to know that it was so well appreciated by the legislature. So it has gone on to the governor. The governor has three options. He can sign it, he can not sign it. In either case, it would go into effect, or he could veto it, in which case it won't. So we are waiting on pins and needles, fingers crossed, that it gets signed or at least gets let to pass into law. And then the next thing that we learned just a few minutes ago, the Board of Public Works was speaking about the contracts for the new FMS, and there are three members of the Board of Public Works: the Lieutenant Governor, the Comptroller, and the Treasurer. And the long and the short of it was that the contracts were withdrawn by a motion from the Lieutenant Governor, and we're not entirely sure what that means. So stay tuned. We will be learning with you what exactly next steps will be, and we'll let you know as soon as we hear. The next thing on the agenda is that tomorrow is our monthly meeting with DDA leadership. We are going to try to bring up things that are of interest to you, and especially we've been hearing from you an interest in what the budget modification process is going to be after the Appendix K ends in June 30th. So we will hopefully have an update for you at least by our next meeting as to what that might look like. And I think that's it for the updates. So we can start our screen sharing. So the meeting is recorded, as I said, and is closed caption, is enabled. Future meetings, May 18th, would be supporting participants through the budget process. And on the 15th, what's going on with self-direction and SDAN. And right now, I'd like to welcome Patti Saylor, the owner of HealthLink LLC and SDAN board member, and all-around wonderful person. So please keep yourself muted. Questions and comments in the chat box, please. And we hope to get to some of those questions after the presentation. So thanks so much.
Sorry.
Well, hi, everybody. Welcome. Thanks for coming. And I hope that I can clarify some things for you going forward about nursing support services in self-direction. So this PowerPoint is a handout available to you in its PDF format on the SDAN website. So like I said, my name's Patti Saylor. I am a nurse. I was also a parent of a young man that had Down syndrome that was in self-direction. He's passed away 9 years ago. So we were in self-direction in the very beginning. And from the very beginning of self-direction, I was providing nursing services to folks who were self-directing. So I've kind of been around this process since the very beginning. Currently, my company works for over 30 people that currently are in one of the DDA waivers. Well, most the Community Pathways Waiver, who self-direct. And over those 16 years, I looked back and I've actually worked for over 200 people. So it's incredible. So I know the burning questions that you have is how do I find a nurse and how do I find training? So we will get to that later. So my disclaimer is I can't go right there. I'm going to tell you what nursing support services are first. There's a lot of confusion, and then we'll get to kind of how do you get this service. The other disclaimer I have is that I can't answer your individual questions about your individual situation or the situation that your loved one has. I can't just be doling out individual nursing advice. So that's not professional on my part. So okay, we'll just dive right into what nursing support services are. Okay, so we're going to talk about these in the following slides, but does DDA mean by nursing support services? What is nursing consultation? What is nursing case management and delegation? What is a certified med tech and what's all involved with that? What is being a certified nursing assistant? When would you need one and what do they do? I'm going to talk to you about the health risk screening tool that most of you should be at least a little bit aware of at this point. And then just a brief mention of skilled nursing services. Okay. Okay, so nursing support services is the label that DDA has given to the services, the waiver services that exist. So the nursing support service is a waiver service available to you in DDA administered waivers. That's community supports, family support, and community pathways. It is required, you're required to have a nurse on your team if your health risk screening tool, your HRST, has scored a level 3 or above. We'll go into more of that later. You're required to have nursing support services, which means a nurse on your team, if your staff that you've hired, your employees, are going to administer meds or do healthcare treatments for you that are related to giving meds. And having a nurse on your team can be a valuable service to help you manage your healthcare needs. I am often met with, I don't need a nurse, I don't want a nurse, I don't need a nurse. Well, consider thinking about the possibility that having one more team member that works for you is a benefit to you. And how can you use that staff person or that vendor that you're hiring, that you choose, to be a benefit and a support to you as one more staff person, one more team member. Okay, Liz? Again, nursing support services is the overarching title. This shows up in your PCP and it shows up on your budget sheet. But when you're talking to a nurse wants to know, well, what do you need me to do? Okay, nursing support service is an umbrella term. And there are 2 nursing support services from the perspective of a nurse that you can choose from. These are the 2 waiver services. Well, they'll call it one waiver service because they've named it nursing support services. But within that, there are 2 different roles for a nurse in self-directed services right now. One is nursing consultation, and we'll go into what these are. The other is nursing case management and delegation. There's another service. There's some services that exist in traditional model services, nursing case management, delegation, and health case management. There is no such thing as health case management alone in the self-directed model. We're going to choose from nursing consultation and nursing case management and delegation. But remember that as far as DDA is concerned, and your CCS may say this, they'll call it nursing support services. But that does not tell the nurse anything about what you're really hiring them for. Okay, so as far as the nurse is concerned, we're still looking at these 2 services under the umbrella term of nursing support services. Okay, let's go on and define these. Okay, so if you have an HRST level of 3 or higher, you know you're going to need to hire a nurse on your team because DDA requires it. Okay. So how do you know what you need the nurse to do? Here's a few questions you can ask yourself. Do you take responsibility for managing your meds yourself? Can you direct your staff to assist you in managing your healthcare or administering your meds or doing any treatments you need? Do you rely on unpaid caregivers like family members or friends to administer your meds or do treatments? Or will you need help from your paid staff to manage your healthcare, administer your meds, and complete any healthcare treatments? So begin with asking yourself those questions. Okay, we can move on. So we're going to define and look at the nursing consultation that falls under nursing support services. when would you want the nurse to hire the nurse to be a nurse, provide nursing consultation to you? You would have an HRST level 3 or higher, because that's the benchmark there. You'll have to have a nurse on your team. You manage your own healthcare and you administer your own meds and treatments, or you can direct your paid staff to assist you, but you're taking the responsibility, or you rely on unpaid caregivers, people who are not being paid with your DDA budget, to manage your healthcare, administer your meds, and complete any of your treatments. Any of those three equal nursing consultation service. Okay. Next one. So nursing consultation is, you would hire a registered nurse who has completed the DDA approved RN training. There's a 2-day free training that nurses need to take if they're interested in working for people with developmental disabilities in anything, in traditional or self-directed services. So that's the training I'm referring to. The DDA, the nurse has taken one of the approved trainings or the approved training for DDA. But look at what the nurse has to do. This is required for the nurse to do if you're getting nursing support services. The nurse has to do a comprehensive nursing assessment. And you know what that is. We get together and I ask you all your health information. I get your full health history and really get an understanding of all of your healthcare needs, right? So that's a meeting with the nurse that you hire. The nurse will do a self-administration assessment to kind of find out, are you able to do your own meds? What assistance do you need in order for meds to be administered? And this helps you and the nurse to decide whether it is staff taking a responsibility or it's you taking responsibility for the administration of your medications. The nurse has to do the HRST rating and review. Now the CCS may do the rating and the nurse comes behind it and does the review, where they will work together with you, your family, and the nurse and the CCS to complete your health risk screening tool. And I'll talk to you about HRST a little bit later. The nurse in this model of nursing consultation can help you to develop some healthcare protocols so that you have some things on paper for what you're asking your staff to do to help you. The nurse can help you develop a way to communicate with your doctors, or maybe find some resources in the community if you need the nurse to help you with that. The nurse can help you, help you identify some resources. Nursing consultation as a waiver service is up to 4 visits per year, no more often than quarterly, for a maximum of 16 hours of service per year, but it certainly can be less. So through that comprehensive nursing assessment, that's when you sit down and you meet with your nurse and they get all your health information, you decide how often, how many hours a year would you like this nurse to be available to you for consultation? And that would be quarterly visits, or twice a year, or once a year, but a maximum of 16 hours. There's no minimum put on this, but a nurse is going to have a sense of the minimum hours. I mean, it takes a certain amount to get all this work done, right? So I just listed here the things that the nurse can do or is required to do. So it can't be done in 1 hour a year. So the specific nurse may have a minimum in their mind of how much we should get to know somebody and how much communication we should have during a year for us to provide a decent service to you. But it's set out that there's a maximum, but certainly in my experience, not everyone needs the maximum. Okay. So what nursing consultation is not? It is not delegation of med administration to your staff. We've already determined that either you're doing it, an unpaid person is doing it, or you're directing your staff to give your meds. So there's no med tech training required of the staff, and there's no delegation from a nurse. There's no direct staff training by the nurse. There is no direct nursing care provided by the nurse. The nurse is not on call. So it is a little counterintuitive here because the service is nursing consultation, but the nurse is making quarterly visits at the minimum, right? So, or at the maximum, I guess is not available to call that nurse and ask medical advice or healthcare advice. It would be assumed that you have your healthcare professionals in your community, that your doctors, that you would be calling for that. Okay, the nurse is not writing a care plan. The nurse is not providing healthcare case management, and the nurse is not visiting or interacting more often than quarterly. Okay. So now we move on to the second role of the nurse under the umbrella of nursing support services, nursing case management and delegation. This is a higher level of service from the nurse. This is required if your paid staff is going to administer meds or complete healthcare treatments. And when I say treatments, it could be things like measuring your blood pressure before giving a med, or taking your blood sugar before administering diabetes medication. So those types of treatments, right? And this would include over-the-counter medications. So any medication that you would be taking that you're asking your staff to give to you then would require this delegation from a nurse. The one exception, as I understand it, is emergency meds. If you have an EpiPen or an inhaler or a diastat for seizure control, a staff person could administer those medications with the proper training to do so without being a certified medication technician. But they still would have to have specific training on how to administer those medications under what conditions. Okay, so even the second box here, even if you are hiring family as staff, okay, if family members are being paid as staff, they have the same requirements of all other staff members. So they also would then be required to have certified medication technician training and function under all those rules during the time they are working for you. So nursing case management and delegation applies to basically anybody, regardless of your HRST level. So it isn't that if you have an HRST level of a certain number, you need delegation. That is not true, but it is likely, right? It is likely that the higher your HRST level means more health risk, that you would be relying on staff to assist you. And so it's more likely that if you have a higher HRST level, you might be looking at having a nurse provide nursing case management and delegation. It is likely, but it is not a direct relationship. Okay. So what is nursing case management and delegation? Again, we're going to look at what is the regulation says that the nurse must do in this for you, if this is what you need. It is a registered nurse that is licensed in the state of Maryland who has completed the DDA 2-day RN case manager delegating nurse training. So the nurse then, when you hire this nurse, they have to do a comprehensive nursing assessment, a self-administration assessment, any other assessments that they, in their professional judgment, are appropriate. Some of the assessments I do might be a choking risk assessment or a fall risk assessment. Again, we're just trying to get the best information possible from you to design the best plan to help you and help your staff to meet your needs. The nurse would be responsible for participating in your HRST rating and reviewing. Again, that's you, your family, your CCS, and your nurse. You know, and we'll talk about HRST a little bit in the next few slides, but the nurse has a role there with you. The nurse will develop a care plan with you, your family, and your staff based on the information that you shared through the nursing assessment. So again, there's the assessments that happen, and all this is discussion between you and your nurse, and the nurse will work with you to write a care plan, and that will be available to your staff to help your staff understand how to best provide for you and support you. The nurse is responsible for training your staff to do the things that are listed in your care plan. Now, I told you I worked for over 200 people. I don't train them in isolation. I train staff to do the things that are in your care plan with you and with your family. So I wouldn't be training them to do something that you didn't agree with. If you like to have your treatments done a certain way or your meds done a certain way, then that's the things that we will put in your care plan. So it's not something that the nurse says has to get done. It would be in conjunction with how you like your care to be done. Would be the best practice. So the development of a care plan, training of your staff, because it's unfair to ask the staff to do your nebulizer treatments if they don't know how to do a nebulizer, right? So the nurse has to train the person in conjunction with you and your family to be able to do the nebulizer treatment the proper way and the safe way. So then the nurse is delegating those nursing tasks and supervising the staff who is now going to be trained as med techs to do the thing that is listed in your care plan. Okay, next slide. We're still on nursing case management and delegation and what that entails. It would be a visit from the nurse that you've hired at least every 45 days, but it could be more often if your healthcare needs require it. And if the nurse feels that it is in your best interest for them to visit more often than 45 days, but it is not to be longer than 45 days. Your nurse is on call for you and the staff, the certified medication technician staff, during the hours they're working. And I am on call. I can be reached by team members during business hours, but I must be available to the staff that has been trained, that is working as med tech and taking care of you, providing supports to you during the hours they're working. That's a requirement for the nurse to fulfill. The nurse will help you identify community health resources. Of course, I say this all the time. I have learned everything I've learned from you. I've learned from people who have lived experience with disability and interacting with healthcare providers. And I've learned from family members. So while the nurse is in a position to help you identify healthcare resources, a lot of what we're doing is networking and letting you know what another family or individual have told us about, the best practitioner that's around. The nurse is to help you develop or can help you develop a way to communicate with your physicians if you need that. The nurse can help you understand your medications and should be helping you understand your medications and their side effects and their effects on you. The nurse can help you to manage your medications and healthcare to the degree you want the nurse's help. And what I mean by this is I work for plenty of people who prefer I do not speak to their doctors. They have a relationship with their physicians that they have nurtured over time. They're not interested in me getting involved in that. But then I have other customers who ask me, can you call my physician and get the doctor's orders? Can you call my physician and help me to help them understand me better? And so I work for the individual who's self-directing. So I will involve myself with their physicians to the degree they want me to be involved. So again, you're hiring the nurse. The nurse is there to help you to manage your health care and your meds, but you can decide how you want that nurse to help you. Okay. So here's a little side-by-side for to help you look at it this way. So obviously, all nursing support services available to you in self-direction require a comprehensive nursing assessment. So it's consultation and delegation, they both require a nursing assessment. Both require the nurse to do a self-administration assessment. That's a brief questionnaire. Both require the nurse to provide recommendations to access health services and supports. Both have the nurse review or update your HRST in conjunction with you and your CCS. In consultation, a nurse is going to assist you to develop your own protocols, or you work that out with the nurse who's doing what, but so that you have protocols for your staff to follow in your home. In delegation, it is required that the nurse develop protocols, and it is required that the nurse develop care plans for the staff to rely on and look at. In consultation, the visits are a max of quarterly and a maximum of 16 hours a year. There is no maximum in delegation. The nurse has to do what it takes to provide the service to you. Sometimes customers I work for need me to visit every 2 weeks for a period of time. And they might be going through a particular difficult healthcare year. And there are times when we're back to just doing 45-day visits. So the 45 days is required in delegation, but certainly could be more often than that. You can see the training of the direct support staff is a requirement for the nurse under delegation. It is not, there's no training under consultation. Monitoring of the direct support and delegating the nursing tasks, that exists under delegation, but not under consultation. Oversight to the CMT trained staff to administer meds and that on-call is required under delegation, but doesn't exist under consultation. So you can see that even though there's an umbrella term of nursing support services, what you're hiring the nurse to do can be vastly different between these two. So when you're contacting a nurse to ask if they're available or you want to interview them, whatever, you've got to be able to tell them what it is you need of them. Where you're looking for nursing consultation, or are you looking for nursing delegation? And yes, you're looking for nursing support services, but again, being specific so the nurse knows what you're asking of them before they can agree to work for you. Okay, next slide. From that nursing assessment that the nurse does with you, that's looking at all of your health information and all your needs and your health history, the nurse should recommend to you the training level of your staff and how to best train your staff. But we can't do that until we know what your needs are, and through having those assessments done, having an HRST to look at, and really just getting to know you some, so we can recommend the best training for your staff. So the nurse may recommend that you hire or have your staff trained as certified medication technicians. So in the DDA system, if your staff is going to administer meds, they have to be trained as a certified medication technician, which we'll call CMT for short. The nurse may also recommend that you consider hiring staff who are already trained as certified nursing assistants, CNA, or both trainings based on what you need them to do. So both CMT and CNA trained staff are certified by the Maryland Board of Nursing and work at the delegation of an RN, of a registered nurse. So again, not at an LPN, but as a registered nurse. So next slide. So a little bit about CMTs. So certified med tech, and I'll go into what those training requirements are in a minute. But this person, it could be just your regular staff person, it could be your job coach, it could be whatever employee you have. But if they're going to need to give medicines to you during the time they're working, they will have to take this training and be certified. They work at the delegation of the RN. They will be giving regularly ordered medications and treatments, or those as needed medications like the Tylenols and the ibuprofens and the things like that that might come up in your life. So but they need to be doing this regularly for you. So you can get into the specifics of that on your specific team and your specific issues. But they work at the delegation of the RN. They're going to be giving routine medications and over-the-counter medications. They are supposed to observe and if there's how these medicines are having an effect on you, if there's side effects, if there's concerns, if there's changes in how you look, act, feel, and they're supposed to notify the nurse. So as far as the regulation is concerned, in this relationship that the Board of Nursing authorizes through the CMT and the nurse, the relationship is between the CMT and the nurse. But in self-direction, it is important to involve you, and it's important to involve your significant others, your family. So if a staff member observes that you have been extremely sleepy after you take a certain medication, they should be letting the nurse know, but they should also be talking to you and talking to your family about it. But the requirement is that the nurse also be involved, not instead of family, not instead of you, but in addition to you. So the relationship between the med tech is the med tech and the nurse, but that should certainly be inclusive of your significant people in your life, your family, or you yourself. Okay. The certified med tech is able to assist you with doctor's visits. They're able to assist you with getting medication from the pharmacy, and they're required to document that they have given your meds the way they were ordered by your physician. There's more to it than that, but we don't have time today to go into the itty bitty details of the CMT. Okay, next. So it brings us to CMT training. It is well known right now that it is difficult to find a nurse available to work in self-direction, and it is difficult to find CMT training. That is a well-known fact. And we're going to talk a little bit about that at the end of my presentation, but let's just carry on here about CMT training. So certified medication training is a big deal. Being a certified medication technician is a big deal. It is certified by the Maryland Board of Nursing in our state. So it is a 20-hour training that utilizes the DDA approved curriculum. It is preceded by a math and reading test that has to be passed prior to even getting to the 20-hour training. The person who is the staff person who's taking this training must complete the full 20 hours in order to apply for the Board of Nursing certification here. So it can't be, oh, I can only make it, 15 hours. So it's a 20-hour training, must have the math and reading test prior to sitting down for the 20-hour training, must complete the full course. You must have a delegating nurse already lined up. Nobody can take the med tech training unless they can identify who their delegating nurse is going to be. So you already have to have that nurse lined up in order for staff to attend the training. The staff person must meet with the delegating RN as the last step of this training. So they go to 20 hours of classroom time, and then the last part of training is to meet with the delegating nurse themselves. So there's a lot of coordination between the instructor of the class, the delegating RN, and you all who are the employer, right? So you are the family member, the individual that is the recipient of services, that you would be the employer. So there's a coordination process there. Costs can range from $180 to $250 per staff for a training, depending on where you find the training. And so that's a budget consideration to put in to your budget for CMT training for however many staff you have. Okay, next. There are 3 curriculums of CMT training out there in the state of Maryland. One is designed for school health employees. Another is designed for employees working in assisted living facilities. And the other is the DDA curriculum. So it was important that you locate a curriculum that is the DDA MedTech training. Okay, make sure that your staff take the curriculum that your delegating nurse will accept. School health training is not appropriate for what we do. Some nurses will accept the assisted living curriculum, but the nurse has to come behind that and teach the specifics that are not included in the assisted living training. So you're really going to want to find the CMT training that is the DDA training. Okay. Maryland Board of Nursing application fee can be included in the cost of the class, but it will be $20 or $30, depending on if this is an initial application or a renewal. And you'll just need to pay attention to that. Is that fee in the class fee, or is it an additional fee? Classes are hard to find right now. So you'll want to share resources among yourselves, contact the DDA regional nurse to ask for resources, and advocate for more choices. CMT training is out there, but it is difficult to find. Okay. Most importantly, stay in communication with your delegating nurse throughout the duration of the training. So if you find a training that you're enrolling your staff members in that training, it's important that your delegating nurse be well aware and be involved in that, so that because meeting with the delegating nurse is the last step of this process. So if your staff goes and they attend a training, a 20-hour training, your delegating nurse should be involved, at least know what's going on, because we have to finesse all of the steps of this process so it all works out for your benefit. So as your staff go through training, there are many intricate steps in this process, and missing any of the steps can hold up the staff certification. So just to keep your delegating nurse involved if you're sending your staff to an organization for training. Okay. So after your staff person completes the certified medication technician training, notify your delegating nurse, because the staff have to meet with them. So your delegating nurse has to be the last step in this process by meeting with your staff in your home, with your meds, with your doctor's orders, with you, to make it real, right? What they've learned in the classroom, they now have to be able to apply to safely being able to give you your meds and do the treatments that are being asked in the work setting, right? So clarify with the instructor what the staff role is in processing their own application, who's doing what. Again, keep your nurse involved, your delegating nurse. Clarify with the instructor how long to expect until the CMT certification will post to the Board of Nursing website. Now, again, you're hearing this for the first time for a lot of you. And you had, at this point, you would have had a nurse hired as your delegating nurse. So you will rely on the relationship you have with your delegating nurse to help go through this process. I'm telling you these things, you know, for many of you, it's new information. But realize that this is, you're in relationship with your delegating nurse that you've hired who works for you or your family member. So keep them in this process as you're sending your staff for training, and they will understand this process, okay? So that was the information about certified medication technicians, right? And we're going to move on to if you feel like you need to hire a certified nursing assistant to meet your needs. And they are two separate roles. The person who is trained to give meds and the person who's trained as a nursing assistant. A nursing assistant would still need med tech training if they're to be giving meds. So your nurse may recommend that you consider hiring somebody who is CNA trained, certified nursing assistant trained, to meet your needs. Your nurse will do this when your care needs are such that your staff should have a good understanding of the basics of providing for your physical care. It's very difficult to train someone to meet your complex care needs when they have no foundation of skills. You may have someone you really want to hire, but your needs are complex, and there's a lot of what you would be asking of that person, and perhaps they should come to you with a set of skills already. So you might be looking for someone who is already certified as a certified nursing assistant to assist you. And I'll show you a little bit in the next couple slides what I'm talking about. Just understand, especially family members, this has been something that's been very clear to me in the years that I've been doing this job. What is second nature to you is often very overwhelming for a layperson that you're hiring. If you're providing for the physical needs of the person you love and medication needs, you've been doing this and you could almost do it blindfolded. But when you're hiring a staff person, they will have the deer in the headlights look. They will not know what you're talking about if there's a lot of physical care involved. So it is important that you consider that your nurse, and get your nurse involved, that you discuss what is the credentials that we should be looking for when we're hiring someone. And if there are complex medical or care needs, I won't even say medical, but care needs, you might consider looking for someone that is already a certified nursing assistant. Now, again, certified nursing assistants must also be trained as certified med techs if they're going to be giving meds. It's not included. So they might have both certifications. Okay, next. So this is, I'm going to call CNA for short. This is a person who is trained as a certified nursing assistant or certified geriatric nursing assistant. They work at the delegation of the nurse you've hired. They are certified by the Maryland Board of Nursing. They can perform activities of daily living and other delegatable nursing functions, and you'll see a list here in a minute. They will observe and notify the nurse of any changes, and you as a family member. Again, this is what the regulation says. We're not cutting out family members or cutting out individuals. It's just that the requirement is certainly for the CNA to report to the nurse. But in my practice, in people I work for, this would be inclusive of family members. So the staff would be observing and notifying the nurse and certainly family members of anything they're concerned about or anything they notice. They assist with physical care, including things like transferring, positioning, ambulating, or walking. They might assist with personal care, like complex hygiene needs, feeding, bathing, those kind of things. And then they, of course, have to document their care. Okay, so go next. So these are all the things that a CNA is trained to do. Now, any one or two or three of these things, we could train anybody to do, right? We have somebody that's interested and cares about the individual and wants to do a good job, we could train to do. But when we look at this full list, this is CNA training, Certified Nursing Assistant Training. And I, as a nurse, am not able to provide a Certified Nursing Assistant Training. They go to school for this. It's a long program. So I can't actually come in, be hired by you, and train a layperson with no skills and no background to do all these things. I really can't do that. And it is conducting a CNA program. It is much more involved than you think. Now, you may do these things for the person you love, but you have done them over time, and you have skill, and you have background, and you have a lot of history and commitment. But we could not take a lay person, one without these skills, and train them on all this. It would be overwhelming, and we're really just not even allowed to. So the nurse and you and the individual family members, we have to look at, what are you asking of this person, and can it be done? Can we train them to do these things? And when it becomes all of these things, then it is too much. And then so you have to work that out with your nurse. So these are the kind of things that certified nursing assistants do. The certified med tech, which we looked at in the slides earlier, just is trained to give meds safely and according to physician's orders and report to the nurse. It's a much smaller scope of what they're doing. Okay, next. So nursing supports and self-direction, things to think about. Again, I've been doing this for about 16 years, since the very beginning of self-direction in our state. So these are just some things that I want to mention to you. Your nurse can be a valuable member of your team if you involve them as a team member, and not simply for the once every 45-day visit or something, but involve them in your team meetings, get them really invested. The nurse who works for you is either an employee or a vendor. For the most part, nurses are vendors. We're independent contractors, and you hire us as vendors. So when you're doing your budget, you need to put the nursing on the right line item. If the nurse is truly an employee, you put it under the employee line item. But if it's truly a vendor, you have to make sure you put it under the vendor, under nursing services. So be careful with that. So the nurse would be working for you. The nurse does not work for DDA, and the nurse does not have access to the LTSS system or your PCP in the computer system. We don't all talk to each other. We work for you. So the relationship is between the person with the disability, family, and the nurse. And then you involve that nurse as much as you want in your team, right? The nurse should maintain your confidentiality and share information with only those people that you give permission for the nurse to speak to. This nurse is your employee, and your health information is private. So you can decide and choose who that nurse can speak to and who that nurse can't. I personally do not share any health information unless I have permission from my customer to do so. Okay? So you have the choice who you hire as a nurse and who you keep in your employ. It's not an assignment. You're not a patient, right? In self-direction. It's just like your other employees. You have choice over who you hire, and you interview and who works for you. You have the right to advocate to have more choices of nurses. Right now, there are not a lot of nurses that work in self-directed services. And we have the right, and we should all be asking for more choices. To have more nurses come into this, into self-direction. And the availability of CMT training. That's very limited availability right now. We should all be asking for more availability of CMT training. That is something that SDAN advocates for on a regular basis. The more nurses, more CMT training. Okay. So things to think about when hiring a nurse. Please caution your CCS regarding how much information can be shared with a stranger. You are not a case, and you are an employer looking for a vendor or an employee. In this case, mostly it's a vendor. You're looking for a nursing vendor. Your personal information is yours to be shared. I cannot tell you how many times I will get an email from a CCS with the attached health information about a person I've never met. And they're basically asking me, will you take this person? And I think in the spirit of self-direction, we need to reevaluate that. Right? So you, in self-direction, you are the employer and you are looking for a nurse that you would like to employ. So the nurses, you are really interviewing the nurse. And it is inappropriate to share personal health information without a person's permission. And for the nurse, in the initial email, I probably shouldn't be looking at people's private health information to decide if I'll work for them or not. Perhaps a meeting with the individual and their family, and to see if we're a good match and if we want to proceed, and then the person could share whatever they would like to share with me for me to get a better picture of what I'd be getting into, but perhaps not just sending out that information to strangers. You are the employer, so you can interview to see if the nurse is a good fit. The nurse is not assigned to you and you are not an assignment. I do a meet and greet phone call, just like you would do if you were hiring a contractor to work on your home, or you were hiring some else, even if you were interviewing a support broker. So we do meet and greet phone calls. And I have 2 this week actually. So individuals will, we'll have an informal conversation to see if we're even remotely matched, and like they would like me to work for them and I'd like to work for them. And then we take it from there. And that is not a paid thing. Nobody pays for that. It's just a simple phone call to kind of see if we should move forward. Here's an important one. This 3rd bullet on this slide is really important. Okay, so you found a nurse and the nurse has done some initial work for you in order to help you get your plan submitted, but the plan has gone in and it's not, you haven't heard back yet, right? So don't assume that the nurse is still available to be hired by you. If 4, 5, 6 months go by, a year goes by until your plan is approved, the nurse may or may not still be available, just like your direct support staff. You may have a direct support staff you have in mind, but by the time you get approval on your plan, that direct support staff is no longer available. So don't assume that the nurse is still available if your plan has taken a long time to get approved. You'll have to go back to that nurse and see if the nurse is still available. And when your plan is approved, that's the time to, or even in between while you're waiting, stay in touch with the person that you're hoping is going to be your nurse going forward. But certainly when you get the approval, you immediately need to let the nurse know, because the nurse has responsibilities then. And perhaps the nurse is no longer available, but if they are, they have to start their work. So staying in touch with the person that is your prospective hire as a nurse. And know that if too much time goes by, that nurse may or may not still be available for hire. And the last bullet on this page about nursing rates and nursing wages. Most nurses are vendors. They are not direct employees of you. So all of the costs of doing business are going to come out of that rate that you hire them at. Business expenses, taxes, workman's comp, malpractice insurance, and administrative costs all come out of that. So, there is a reasonable and customary wage, and that is published. You can see what the top rate can be. But know that, so if the top rate right now, I guess in some counties is 75, 40, 75, 50, something like that per hour. Well, all of the cost of doing business must come out of that. So I've seen a lot of times on the SDAN page, Facebook page, people are alarmed at that rate. I have to bring it to your attention that 75, whatever, is not going in the nurse's pocket. right? That has to pay for the cost of doing business. Because this would be a vendor. You're not an hourly rate. It's not an employee rate. So consider that when you're talking to nurses and they're telling you what their hourly wage is, this would be, or their hourly rate is inclusive. They have to pay their taxes, their workman's comp, their malpractice insurance, and any administrative costs to work for you. So it is not the money that's going in their pocket as their hourly pay. Okay, next. The health risk screening tool. By now, most all of you should be aware of this. This is that assessment tool that is used that DDA requires for everyone, and it gives you a score of 0 to 6, and it is assessing your health risk. It is required by DDA to be done when you come into DDA services, and at least annually. It is submitted to DDA with your person-centered plan and if you have a revised plan. So you've done this with your CCS and perhaps your nurse, where there's lots of health questions in there in the questionnaire. Initially, the information is entered by your CCS. You're going to score from 1 to 6 on this health risk screening tool, which I'll call HRST going forward. It will generate a score of 1 to 6. If it's a level 3 or above, a nurse must review it. Okay, so because a layperson, a CCS who's not a medical person, has taken your information that you've given them and put it into this risk screening tool, and it has generated a level 3. Well, now a healthcare professional is going to take a look at it and might ask some more questions. Okay, so when you enter DDA services for the first time, the initial review of by an RN is going to be done by an agency that DDA contracts with, because you don't have a nurse on your team yet, right? You're just coming into DDA services, and an agency, right, is going to do that review. The CCS might do the initial rating, and then the review, if you're 3 or above, will be done by a contracted agency. But once you hire your own nurse on your team, your nurse will be doing that review. So your CCS may put the information in and your nurse will be looking at it. And so this is something that you all participate in. You have a say in what goes into your HRST, how it's answered, what you want to have show up in this screening tool. And then your nurse is going to come behind, and for this to be a good document and it really reflect your needs and your risks, you're going to work with your nurse and your CCS so that the answers that are in this HRST document really reflect your needs. You can ask the nurse to work with your CCS. I work with many CCSs, some of which are on this call right now, that we get the best health risk screening tool that we can that really reflects a person's needs. There shouldn't be any surprises, right? But here's an important statement for all of you, and this is still a problem. There is no such thing as a standalone HRST review done by a nurse. Every single day, I get a request that somebody needs an HRST review. Well, that might be true, but if you look back on what we talked about in the 2 services, the nursing consultation and nursing case management and delegation, it starts with the comprehensive nursing assessment and a self-admin assessment. So the nurse has no ability to do this one thing for you, just an HRST review. It's part of a bigger package of nursing services, right? So there's no such thing as a nurse just coming in and doing the HRST review by itself. But I continue to get requests just for that every single day. And I can't do just an HRST review. The regulations don't allow that. I have to do an assessment and a self-administration assessment. And I have to then do the HRST review. So please understand that. So when a family member or a CCS is contacting a nurse, you aren't just asking for an HRST review. You're asking for the person to get involved as providing nursing support services. And we talked about this. It includes consultation or case management and delegation. So it's more than it seems. The HRST is important in supporting your need for support services. So make sure that you have input and that the HRST that exists is accurate. So if you are in a situation now and you don't know what your HRST is and you don't know what it says, then work with your CCS for them to share it with you. Or if you have a nurse on your team, ask for your nurse to share it with you. It's not something that you directly have access to, but that your CCS does. And if you have a nurse on your team, your nurse does. So you should clearly know what this says about you. And you should have true input into the answers on this health risk screening tool. Next. Okay, the health risk screening tool is laid out in levels of 1 to 6, with 6 being the highest. And this is measuring your health risk. It is not everything about you health-wise, but it is a tool that is used across the country, and Maryland adopted it several years back. And it can give you some good information, but it should be reflective of your true health risks. This level that like when you answer all these questions that your CCS or your nurse give to you and you're doing the HRST together, it shouldn't be a surprise. You already know what your health risks are. This is just a way of capturing it all in a document. But it verifies your health risks and your health needs, and actually then supports your need for the supports you're asking for in your person-centered plan. So level 1, you would expect to not have high health risk. Level 6, you would expect to have some high health risks, right? Now, the other thing to remember is that the risks may exist. You know, I work for many people that have an HRST level of 6. Good care, good family involvement or staff involvement mitigates those risks. So a person stays healthy and stays out of the hospital and stays alive and isn't hurt, but the risks are still there. So you want to make sure that you use this tool to show that the risks are there and what is being done to keep people healthy and safe, right? The HRST also identifies your staff training needs. So when you complete this, it is real clear where you should be training your staff and on what by using this document. I don't have time in this presentation to go through all of the health risk screening tool and all the different components of it, but you know there'll be the front page of it that'll have your name, address, phone number, and that kind of information. Then it'll have the second will be your list of diagnoses, and you want to get all the diagnoses in there, right? So somebody reading this really gets a picture, right? And the next will be a list of your medications, and you know it may not be kept up in real time. Hopefully your nurse can keep it up with new information as your meds change, but at least annually it will be an accurate list of your medications and all those medications that have been discontinued. So your input is important here so that what gets written down about you is accurate. And then there's all those rating areas, and most of you have already gone through an HRST, so you know there's rating areas and you're asked questions and you give an answer between 1 and 4 and generates an HRST level, right? Okay, so next slide. This is the one and only slide on skilled nursing. So what I've talked to you about before was nursing support services that are in the waiver, the Community Pathways Waiver, where we find self-directed services, right? We have nursing support services that include nursing case management and delegation and nursing consultation. Some people that receive DDA services really require a nurse, skilled nursing, a shift like 8 hours, 12 hours of direct nursing care. DDA does not have a waiver service that provides for skilled nursing care. That doesn't mean it's not needed. It just means that DDA does not have a waiver service that provides that. The one source of that shift nursing for direct skilled nursing that exists currently is REM medical assistance. REM stands for rare and expensive case management, and it is medical assistance. It's kind of a carve out in the medical assistance service administered by the Maryland Department of Health, Division of Nursing, not DDA. REM has its own process for eligibility for REM services and its own process for eligibility for skilled nursing services. So one can be eligible. No, I see that question, Stephanie. I'm sorry, I said popped up on my screen. Delegating nursing is not direct nursing care. Delegating nursing is The nurse delegates a task to a staff person who is trained as a med tech or trained as a nursing assistant to do that, whether it's to do a blood sugar test or to do an inhaler or to give a medication. The nurse retains the responsibility, but the staff is doing that work. Okay, that is not shift nursing. If a person requires a nurse, DDA is not paying for shifts of skilled nursing. It is not a waivered service right now. Now, somebody somewhere across the state could be having DDA pay for it. That is not what I'm talking about. That would be a situation where an individual situation has escalated to the point where DDA is providing that service. But as it stands, skilled nursing, which is shift nursing, like a whole 8-hour, 12-hour shift of nursing, is not a DDA waiver service. The only place that is currently available is through the REM program, which is medical assistance. You would know it if your medical assistance was REM, right? So rare and expensive case management. And there is a service under REM of skilled nursing. You have to be eligible for REM and then found eligible for nursing. And you can have REM case management without being eligible for nursing. So don't get them confused. When we talk, generally in self-direction, when we're talking about nursing, we're talking about delegation of nursing to your med tech staff. Let me stop right here and tell you one of the differences. For us to delegate, for a nurse to be able to delegate something to a lay person, a person that is not medical in nature and not medical training, a med tech or a CNA, what I'm asking of them to do has to meet some criteria. Say I'm asking them to test your blood sugar. Well, your health must be stable, chronic, predictable, and another nurse, uncomplicated, and another nurse would agree with me. So treatments and meds of a routine nature, something that we could allow a non-nurse to do, right? So otherwise, a regular staff person cannot do it. So a nurse is going to be thinking about that. Say that you need your blood sugar tested, right? So through my assessment, I'm going to be talking about that. I'm going to be looking at that. And in my mind, I'm going to say, is it routine? Is it chronic? Is it uncomplicated? Can we ask a staff person that's a med tech to do that? Is it going to be safe for you if we do? So all that thinking goes into that decision. And I can't just say, oh, any staff can do that. We'll just show them how. No, it's much more serious than that. So there's a lot that goes into your nurses thinking as they support you and help you. And that anything more would be too much for this conversation. It's a conversation to have with your nurse that's on your team. Okay. So some people, it is complicated and it is unpredictable, and their healthcare would not be safe for an unlicensed person to do. So that the person may need a nurse on their team to provide direct nursing care. And I'm telling you just by this side that the one source of that right now is medical assistance for direct nursing care, because there are things that a regular old staff person just has no business doing, right? Now, I know, and you know, if you're parents on here, that you have been doing high-level nursing interventions for your loved one since the day they needed it, but you weren't being paid by Medicaid money, right? So our support services that we get through the waiver are Medicaid money funded. And with Medicaid money comes rules. So yes, you can do all of these things as an unpaid caregiver, as a family member or someone who's not receiving payment. And I understand that, but if someone is being paid out of their DDA budget and there are staff involved and this is Medicaid money, there are rules and we have to abide by those rules in order to protect your funding. So if you want your waivered services and your DDA support, the money that's in your budget, we have to abide by the rules as they are. So I know that many of you as family members do all of these nursing tasks without being a nurse, without being a med tech, any of that, but you're unpaid. You're not paid by Medicaid dollars. If a family member is on staff, the rules apply, and the family member would have to be trained as a med tech. Okay, next. So the $1 million question, and what comes up every single day, is, so where do you find a nurse? And where do you find CMT training, med tech training? Well, right now, the demand far outweighs the supply. And we know that. Everybody knows that. And SDAN advocates for more supply. So every single month when we meet with the leadership of DDA, I'm the lone voice, saying we need more access to CMT training. We need more nurses. So we, on a systemic level, we are pressing for that to happen. On a local level, what you can do is share with each other. If you have a resource for med tech training or a nurse, put it in the chat and share it with these other folks that are self-directing. If you're a nurse that provides nursing delegation or nursing consultation services, put it in the chat to let people know who you are. So outside of this presentation, it could be on the Facebook page. Share the information among each other, because right now there are not enough nurses and there's not enough training available. SDAN is working on that as a systemic issue, but in the meantime, we have to rely on you all to share with each other. Ask your support broker. They work for multiple people. They may know of other nurses that are working and other places for CMT training. Your CCS, or if you have an inexperienced CCS, ask to talk to the supervisor. Find out where they're getting, do they know of nurses? Where are people getting CMT training? Here's an untapped source, provider agencies. Now, traditional services, they have the same rules, right? They have nursing delegation and they have nursing case management, and these individual providers hire nurses. Well, they are also running training. They're doing CMT training on a regular basis because they have to have CMTs for their business. So ask them, if you have an ARC in your area, or you have a community living, or you have a Jewish Foundation services, or you have any local provider in your area, approach them. Ask them if they would accept people in self-direction into the staff, into their med tech classes. Many are doing that around the state, but it's very informal and not many people know of it. So it's worth asking if they have a way for you to send us one of your staff to one of their trainings, their 20-hour med tech training. So tap into that. CCSs, you have relationships with these providers because you have individuals you work for that are in provider services. Perhaps you could negotiate some of that. I'm hoping that we can work with DDA for them to help to open these providers to the possibility that people working in self-direction could attend their classes, but do it on your local level as well. So DDA regional self-direction leads, there are people at each region that do self-direction, right? There's a self-direction lead. And each region has nurses. I'm going to give you those names. If you go to the next one, the next slide, here are some resources. Here's the DDA regional self-direction leads. You'll recognize those names if you live in those particular regions, right? Perhaps they'll know. There's regional advocacy specialists, Cheryl and Cody and Jessica. They are all work at the regional level. Now, not just in self-direction, but they exist to help people problem solve who are receiving DDA services. And next slide. These are the regional nurses. Every region has nurses. The one position they have at the region is called DDA Health Services Liaison. You'll recognize some of these names if you've dealt with the regional nurses. And they have a quality enhancement nurse administrator. So there are 2 nurses at each regional office. And it's important for them to know what you're struggling with. If you can't find training or you can't find a nurse to work on your team, it's important for them to know. And many of you know me, that I have been the lone voice on this issue for a very long time. I can't fix the problem and create more nurses in self-direction or to create more avenues for CMT training. But SDAN will continue to work on those issues on the statewide level. But go ahead and, well, thanks. Somebody's putting in the chat that there's a new advocacy specialist. So that's great. I didn't have that information when I made up the slides. But, contacting your region saying, we've been trying to find a nurse and we can't find one. And we've been trying to find med tech training and it's not available. I mean, it's nice for them to know, and perhaps they will help to get this worked out. So there are more nurses available and there's more CMT training available. So that's the information there. So, okay, now I know that there's been a ton of questions probably coming in. Alicia's been monitoring that. So again, I cannot work on your individual issue, but if there are generalized questions, I'll certainly take them.
Okay, I have a few. So the first one was an HRST. Who does that? And I think you've answered. I think I heard you say that the HRST initial ones are done by the CCSs, and if the level is 3 or above, it has to be reviewed by an agency that DDA has hired to do that. Is that correct?
Yeah, currently the contract for that is with Optimal Health. And so if a person's coming into DDA services, the CCS does the original HRST questionnaire with you as the participant. And then if you have scored an HRST 3 or above, it will be reviewed by Optimal Health. But once you're in the DDA system and you have a plan and a budget, and if you need nursing services, you would be having your own hired nurse, right?
Thank you.
Team.
So somebody asked a very specific question, but can CMTs administer O2 treatments, PRN? And so I guess that if you could answer that question, that'd be great.
But
otherwise,
everything starts with a nursing assessment. So the nurse has to have a lot of information, right? We just know that there are certain things we can't delegate at all. There are other things we can delegate under certain circumstances, in which case we'd need more information to make a judgment about that. And then there are some things that we automatically know we can delegate. So
okay.
That would be a question that I'd have to know all the circumstances of. It is possible, but it is not automatic. It's
Okay.
not
so
automatic.
there is no list then of can and can't. It really is person specific.
Nursing is an art form. It requires taking in information, using all your best judgment and information you have about someone, and then making a recommendation. So there are places where it's not black and white. It is based on the nursing assessment of information and the judgment call of the healthcare professional. So there are some guidelines, but it all starts with a nursing assessment. So the nurse has a lot of information to work with before they can make a recommendation to you.
Great.
There are some things we know are absolute, right? We cannot have a med tech doing deep trach suctioning. Like that's an automatic. We know that one, right? And we know it's automatic that the med tech can be doing routine oral medication. But those things that are in the middle there, really takes a lot of information. The nurse gets to know the individual, and we make the best nursing judgment. Sorry, it's not as black and white as people would like it to be.
Yep. Well, things rarely are. So another person was asking, who does the nurse submit their assessment to?
You hire the nurse. The nurse is your employee. The nursing assessment should be given to you. Right. And it should also be if you're doing, if staff are giving meds, that nursing assessment should be on site in your home in a med book. The DDA could request the nursing assessment, in which case with permission, the nurse would send it to DDA.
Okay. But it's not automatically sent to DDA necessarily.
No.
Okay. So I don't know if you know this, Patti, or maybe even Carol or somebody else might know. Somebody was asking what line the nurse vendor budget line is.
I don't know the number or what line it's on there, but I do know that nurse as employee comes first on the budget sheet, and nurse as vendor comes under that. And so oftentimes it gets written in as employee because people aren't paying attention. So if you really intend to hire the nurse as the vendor, you've got to find the vendor line under nurse, and it will be nursing support services, employee, or nursing support services vendor. So you have to pay attention to it.
And really most of the people, I mean, a gross majority of the people do use the vendor as a service. Very few people actually have the employee. Is that correct?
Yes, well, most nurses are contract employees. They're running their own business, and they are either an LLC or an S Corp or something. So they're contractors, not necessarily employees. But there is a way to have the nurse as an employee also.
Great. And I sort of did answer this question in the chats, but somebody was asking if medications need to be blister packed. And I said, just from my own personal experience, that they didn't, but I thought you might want to elaborate on that.
So according to the med tech training and nurse training in that DDA puts out, it is the preferred method is to have blister packing, but that if the team meets, your team decides that it is safe and it is appropriate, and the family gets their meds from CVS in bottles, then we write it into the plan that it is the preferred to use CVS pharmacy and to forego blister packing. But the nurse is thinking that through. Is this safe? If you have 9 staff all touching those meds, is it safe to have 6 bottles of meds somewhere? Or would it be more safe to have a blister packing? So again, there are a lot of thought goes into these decisions, and DDA in the training, in the med tech training and the nurse training will say blister packs. But if we prefer to not do that, a team prefers not to use blister packs, it should show up in the person-centered plan and as to why.
Okay, thanks very much.
And most people don't use them because CVS doesn't blister pack.
Right,
or
right.
Walgreens.
So I wanted to point out to everybody, links to a lot of the things that Patti was talking about are now in the chat box. If there's anything you want to, click on and download. Also on our website, marylandsds.org, we have most of these references listed on our website as well. I think you got a bunch of compliments on how well you made a complicated topic much easier to understand. Here's one other. If you get paid as staff, are you able to give medication off the clock?
Okay, here's, so that's a good question. So that first, DDA would certainly frown upon any decision to try to circumvent the regulations that are in place for your safety. So people are trained as med techs because they learn stuff and they have knowledge then. And we try to circumvent that by having them give off the clock, give meds and go back on the clock. DDA is going to frown upon that. Okay, the regulation is there for your safety. And in that 20-hour class, there's a great deal of good information. So it would not be appropriate to have staff go off the clock, give meds, go back on the clock. That's not an appropriate team decision.
Thank you. And then I guess I would like to ask, as a participant family member,
and CMT who works on my license.
And a CMT works on your license. I would love to find out where other people are getting their CMTs trained. I know there's some people who said they're looking for a spot, so I highly encourage you all to use our Facebook page to share information. If you have a place that you are using for CMTs to get their training, please share it with everybody else. And likewise, as Patti asked for nurses who might be available to be a delegating nurse or to do consultation. The more we can work together to solve this problem, the better off we'll be. And again, as Patti had suggested, conversations with our regional offices and the regional nurse liaisons, they don't know there's a problem unless we tell them there's a problem. So if they get inundated by, nice requests for assistance, we can't find one, they're more likely then to spend some of their time helping us look for those opportunities for training and for nurses. So highly encourage you to be in communication with those offices. We will meet tomorrow with the DDA upper level management, and it is a recurring issue and we'll be again tomorrow about trainings and nurses. But the more you guys help out, the more people across the board of DDA will realize this really is an issue that requires some attention.
Right. If I could say one more thing, I know we're long on time today, but it is a complicated issue that is difficult for people to get. There are people who will have needs that require their staff to do something for them that really a nurse should do by regulation, but they don't qualify for nursing. They don't qualify for REM. So we are looking at that issue. Here's a typical example of that. A person who has diabetes that is not particularly stable, who may need something at any given time through the day, right? It is not simply insulin in the morning, insulin at night, or something to that effect. So somebody who has is uncomplicated, because remember I said it had to be kind of chronic, stable, predictable, uncomplicated for a layperson, a staff to do. So a person who may truly, their staff cannot do their medicine and cannot do their treatments, but they don't qualify for nursing care under REM. So we're looking at that issue, but it would be nice if that is the situation any of you find yourself in, that you don't qualify for REM medical assistance, but you also can't ask your staff to do these things because a med tech can't do them. They're too complicated. I need to know who you are. So you reach out to me, and we're trying to gather those folks so that we can present that issue and ask DDA and the powers that be to help us come up with a solution. Because if your staff can't do it, because the regulation says it should be a nurse, but the state has no way to pay for a nurse for you, there's no program that you would be eligible for, then you're in a gray area that leaves you stuck, right? So we want to know if you find yourself in that situation, that let me know, and we're gathering those people and having conversations with the Department of Disability and with DDA to illustrate that there are folks that get stuck. You have this great self-directed theory and going out and have a self-directed life, oops, except you need a nurse. And oops, there's nobody paying for your nurse, right? So we have now created a situation where people can't get their need met. So if that's you, let me know.
We had one other question, which is maybe a great opportunity. It says somebody on our webinar says they're a CMT trainer for assisted living. How can they become a trainer for DDA? Do you know that?
You have to take the 2-day free course that's offered by the regional nurses. It's on the DDA calendar for training, the training calendar. So in order to be let me make sure, this is to be a delegating nurse in the DDA system, right?
The question was to be a trainer,
Right.
like a CMT trainer.
It is taking the 2-day case management and delegating course with the regional nurses that's offered every month or two in one of the regions. It's on the DDA calendar, training calendar. And then that qualifies you to be a delegating nurse in DDA services and teach the MedTech course.
Great, thank you. I hope you are successful in getting that done. We would love to have another place to get a CMT training. So, well, thank you, everyone. Thank you, Patti, for this information. And do check out our website if you need these links again, if you didn't get them from the chat. And we look forward to seeing you again May 18th for the budget webinar. And in the meantime, please do keep in touch. info@marylandsds.org will get your information to us. The more we hear from you, the better we can serve you. So thanks again.